I actually find this topic very interesting. It's very relevant to my life. I'm working palliative medicine and hospice, and we obviously see a lot of people at the end of their life, and it's not infrequently that I'm asked this question, and people will ask me, or I would say it's not frequent, but it's definitely not infrequent that people want to know how they can either assist themselves or, will we prescribe that? And we have to explain that, no, this is illegal in the state of Texas and things like that. So we're just going to go through this a little bit. And this is very freestyle. Raise your hand if you have a question, especially as you well know by now, doctors are horrible about acronyms. I even can't read other people's acronyms sometimes, and I have to Google, what does this mean? So if I have said something that you don't understand, just raise your hand and let me know. And then we'll have some time for discussion at the end, of course. Oh, you know what? Do I have a way to advance the slides, or you want me to just tell you, or what?
Oh, okay.
Yeah, I'm good
It's
to
okay.
do it. Yeah.
So we're ready to advance.
Okay.
So I would like to, just for 1 second, if I'm just totally curious, if y'all will all close your eyes just for a second, I want you to raise your hand. Everybody's eyes closed. If you are pro physician-assisted suicide. Okay? And then raise your hands if you are against that idea. Okay, thanks. I'm just curious. I'm not going to share your answers. I just was wanting to know. Okay, so forward. You guys have probably all heard of Jack Kevorkian. He is the person that really brought this to the forefront. I was back in high school when this was all going on, so this is not remote history for me. Actually, I think I was already in college. So, but he was actually, what I thought was interesting when preparing for this talk, I did not know this, he was a pathologist, which I found kind of fascinating. So he probably had very little patient interaction, and to kind of become the, known as Dr. Death is kind of interesting. But he did challenge a lot of our viewpoints. And one thing I think that he did that was really good was he really helped the palliative care movement in the sense that he opened up discussions about death. So he was the first one. Can we go ahead and do our next slide?
Yeah, just.
Sure.
Thanks, Parker.
Oh, yeah, thank you. Can you just push the lawyer over?
Again?
Oh, no, sorry, I didn't realize we'd gone on. Okay, so he invented this machine, and what I think is very interesting is it's very, very similar to what we use to, in most states, to use for capital punishment, but yet it's considered, inhumane for capital punishment. But he basically invented a very similar thing, and it was okay when he did it, which I thought was kind of. But anyway, physician aid in dying is defined as physician providing, at the patient's request, a prescription for a lethal dose of medication that the patient can self-administer by ingestion with the explicit intention of ending life. And want to go ahead and thank you. Sorry. So Oregon is the first state that had this law. It was originally passed in 1997, and it was upheld later at the Supreme Court level. And one of the things we're going to talk today about, and one of the things I spend most of my day teaching, is choice of words and language. And so I feel very strongly that we have to choose our words very carefully, because we want to promote an atmosphere of discourse. And we want to have everybody be able to share their view without feeling like they can't express it. And, one of the things I think that we have done in the past 40 years or so that is very unhealthy to just promoting discourse is by using language that sort of vilifies our proponent. In other words, like, for example, is the right to life and pro-choice debate. A lot of times the extreme right will use words like pro-abortion, but nobody's pro-abortion. Even people on both sides of this issue all can agree that we want to have less of that. So it's just an example, and I think, we live in a society that wants to be super polarized, and so I will be trying to choose my words very carefully, and I think it's important for all of us. So, but you want to go to the next slide? Thanks. So why do patients choose this? You would think that they would say because of pain, but that's actually really far down on the list. Most people do not like feeling out of control and loss of autonomy. They feel like they can't do things that made life enjoyable, loss of dignity or loss of control of bodily functions, burden on friends or caregivers, and pain and financial concerns are pretty far down on the list. So that's from a JAMA study. And then, go ahead, thanks. There's a bunch of current safeguards in place that are supposed to allow this to be done in a way that people aren't slipping through the cracks that really we shouldn't be doing this to. And the first one is a mental health evaluation. The only problem with that is that it doesn't happen very often, if at all. And so in Oregon, about 5% of patients who request physician aid in dying actually end up seeing a psychiatrist at some point. So there is always that concern that people can become very depressed, and is depression affecting their ability to make a good decision?
Just from a definition standpoint, so is physician assisted death, does that refer to like, hey, we're gonna just start ending your care, or is that I'm gonna apply a drug that's gonna be a lethal dose? Or is it both?
No, it's I'm going to give you something that you can take home so that you can end your life.
Okay.
It's very specific to that, yeah. All that other stuff is more like palliative care. That's what I do every day.
Right.
Yeah. And so, so that's been a concern, that there is not a lot of intervention there. Okay, next ones. So, what drugs they actually use? It used to be phenobarbital, but I don't know if you guys are aware of this, but really about 99% of the medications we use are not manufactured in the United States. So other countries that make this, who are opposed to the death penalty, stopped shipping it to us. So the cost has skyrocketed. Anytime demand goes up and the supply goes down, our pharmaceutical industry is quick to respond with very expensive prices. So it's cost prohibitive now. And now they use secobarbital, but that too, the price has become very high, because that was the alternative that people started using then for capital punishment. So now they use a phenobarbital chlorohydrate morphine sulfate mixture that they compound. It's about $450 to $500 in Oregon. So, and then just to give you a comparison, a typical dose of phenobarbital, which you probably never use anymore, the only person I've ever, I think vets use it now, but then we don't use it for people very much at all, because it's super addictive. It causes a lot of sedation, but it was originally a drug that was used for seizure disorders back before they had a lot of better choices. But a usual dose for them would be 100 to 200 milligrams at bedtime. So you can see it's a way, way bigger dose. And secobarbital is usually about 100 milligrams. So that'll just give you kind of a reference. Yeah, thanks. So there are 8 states right now that have laws in place for physician-assisted death, and they are California, Colorado, District of Columbia, Hawaii, Maine, New Jersey, Oregon, Vermont, and Washington. And as far as I know from reading, there are not other states considering legislation at this time. So that's about it. Does it contradict the Hippocratic Oath? Well, of course, everybody has a differing opinion about this, but the Hippocratic Oath, of course, is first do no harm, is what it's based upon. And he specifically says in this language, I will neither give a deadly drug to anybody if asked for it, nor will I make a suggestion to this effect. So, thanks. Opponents say that to physician-assisted death, say that it is not supposed to be, it is not consistent with Hippocratic Oath. But then there is also, go ahead, on the other side, people who are proponents of that say that, number one, the Hippocratic Oath is outdated, and that even though it is against what this man is saying, what Hippocrates originally said, it is okay because of it alleviating suffering, and there are other ethical issues that are more important. So that's kind of the thinking on that. So what does hospice think? It's interesting because most hospices will take a position of neutrality. And basically what they're saying is, we won't do it, we won't participate, we won't allow our physicians to do it, but they rarely come out and say, no, we just think it's a bad idea. And that's because they have, number one, hospice is a business, and if you say that, those people are not going to come to you, right? Which is a sad reality, but it's the truth. And then number two, they want to, their moral obligation is first to the patient, and they feel like they want to be around to help the patient in case something goes wrong. but they are not usually allowed to participate in the process at all. So, and then NHPCO, which is AAHPM is the American Association of Hospice and Palliative Medicine, and it is the more palliative side of our two organizations. And then we have NHPCO, which is the National Hospice and Palliative Care Organization. They were originally just hospice, and AAHPM was originally just palliative medicine, but it's kind of weird now, they both do both. But they are actually outspokenly against it. And they feel like that there's just not enough information to safeguard patients at this point, and so they are negative on that. Yeah, keep going. Yeah, AMA is opposed, and they actually just recently put this up for a vote again, and it was again not passed, but the margins are getting smaller and smaller. So, whereas originally when they brought this to the AMA, they voted and it was like only like 30% of people in favor of that. Now it's up to about 45%. So the tide is kind of changing. And I do think their points are pretty consistent with what most people who are opposed think. That it's incompatible with the physician's role as a healer, it would be difficult or impossible to control, and would pose serious societal risks. Let's see. So the American College of Physicians opposes it for about the same reasons. And there are a few organizations that support it. And I think it's very interesting that the American Medical Women's Association does, and also the American Medical Student Association does. So get active. And most people's argument is the whole slippery slope argument, which slippery slope is an idea or a course of action which will lead to something unacceptable, wrong, or disastrous. And so in this case, it's allowing healthier and healthier persons the right to end their lives. And I do think it is interesting that the Netherlands, who has the most progressive legislation in this particular arena, originally said you have to have a 6-month terminal diagnosis, and then said you had to have a 12-month terminal diagnosis. And now currently there is no cap at all. It basically, you have to have a serious illness, but you don't have to have a terminal illness. And in the same way, Australia has gone from 6 to 12 months. So there is definitely some shifting along that slope going on. And so if you are pro, you will probably find that to be a good thing, but if you are opposed to it, you may not. So that's what most people are concerned about. Do patients actually go through with their scripts? The only data I could really find on this is in Oregon, and I think it's because their law is older, so they've had a lot more time to study it. So really right about 2/3 of patients actually take their prescription, but that means 1/3 don't. And my experience with that has been, I've had a few hospice patients who obtain the prescription out of state and then come back in state, and their feeling is, I don't necessarily want to do this, I just want to know I have it, just in case things get so bad. And I think a lot of that is an opportunity to, for me at least, as a palliative care and hospice physician, to really reassure them, and studies do show that the presence of hospice and palliative care, people utilize this at a lower percentage rate than people who get the prescription and don't have hospice and palliative care. So the question is then, does Oregon predict the future? And probably so. I mean, if you look at what's been happening around the world, as these laws pass, they tend to become more utilized and more progressive. But the nice thing is in Oregon, 93% of patients who died with physician-assisted death were on hospice at the time of their death. So they're still getting hospice support, which is, I think, a good thing. And that, like I said, that's our chance to kind of talk to people and understand what their concerns are and why they're choosing that approach. So Oregon data is similar to previous years. Most patients are 65 years of age or older. Most had cancer, most were on hospice, and most died at home. Most of them, almost all of them, had health insurance, which I think is interesting, because I think some people will argue that physician-assisted death is bad because they worry that people will choose it because of health concerns about health costs and finances, but that has really not been a fear that has borne out. So we're going to talk about some specific cases that have helped set the laws and what happened with those. The first one is Terry Schiavo. She was a lady who had a cardiac arrest in her home. She was very young. She was only 26 at the time. She was resuscitated, but she had a massive brain injury due to oxygen deprivation. and was left in a persistent vegetative state. She had 2.5 months without any improvement, and then for the next 2 years, doctors attempted occupational therapy, speech therapy, physical therapy, other experimental therapy, hoping to return her to a state of awareness without success. In '98, her husband petitioned the 6th Court of Florida to remove her feeding tube pursuant to Florida law, because he said that she did not have documented preferences, but he said they had discussed it and he was her next of kin. So her parents did not agree and did not agree with her diagnosis of persistent vegetative state. They determined that they basically went through a very long court battle, and then finally in 2005, the tube was removed for the last time. It was removed and put back and removed and put back many, many times. And then finally it was removed and she passed away on hospice. But one of the things that I think about this case that has been really important is it really started to make us aware that we have to have goals of care. Just out of curiosity, how many of you guys have a medical power of attorney or an advance directive? Yeah. Stan does. I probably bugged him about that. No, I'm just teasing you. But yeah, it's shockingly uncommon in your age group, but you really should. And you can download them right off the internet. And it's kind of funny, when my husband and I were in med school when the whole Terry Schiavo case was going on, and what we figured out was that, we really didn't know what the other person wanted. Because I was like, I don't want to be that person ever. Don't ever put a feeding tube in me. I was very aggressively against being kept alive like that, and he did not share that feeling. So it is good to have these conversations, because he was very surprised by my opinion and I was quite surprised by his opinion, and we were both like students and had never talked about it. So I think it is important to have those conversations.
Question, so if someone doesn't have has a designated medical power of attorney over the
your next of kin is able to provide that service.
Okay.
Basically,
so if you're married, it would be your spouse, or if you weren't married, I guess it would be your.
There's a specific in the Texas code, and it differs from state to state, but in Texas, it's first your spouse, next it's your adult children if you have them, then after that it would be your parents, and then it would be a sibling.
Okay.
So, and then it goes all the way down to like a chaplain at a hospital. I mean, because if you just have nobody in your life that can do that. And then even if that person is the next of kin, they can pass that off. So like, let's say they have adult children, but they're 19. They can defer to their grandparents, and let their parents be make the decision maker. Does that make sense?
Yes.
Okay. And then most recently, Brittany Lauren Maynard has been in the news. I don't know if you guys remember that case. That's definitely been while you were adults. So she was diagnosed with a large astrocytoma. And for those of you that don't know, it's a very difficult brain tumor to cure, because it's called astrocytoma for a reason. It reaches out with all these little projections. So almost never do you get clean margins when you resect it. And so she did not do well, and she had a recurrence and was given less than a 6-month prognosis. She chose to move to Oregon and obtain a lethal prescription. And I think what really surprised people was how early in her illness she decided to do that. And I think that's what brought this case in particular to the forefront. It was not available in the state where she lived, so they moved to Oregon to obtain the prescription and live there. And then she was very open and had lots of publicity surrounding her passing. So, and then the next kind of famous case is a guy in France, and it is not legal in France, but they do have what they actually call it passive euthanasia, but it's really palliative care with sedation. And it's not euthanasia, because it's just allowing a person to die naturally after removing life support, right? So that's not euthanasia, but they call it passive euthanasia. If you read press coverage of this, it talks about that, and that's one of the main reasons I brought it up, because I wanted you to understand exactly what they're talking about. They're not talking about anybody actively doing anything. They're talking about only removing stuff. And again, it's a case where the wife wants to remove feeding and hydration, and his parents want it to stay, and they are still divided about this case, and it is still in court. But that was the main reason I brought it up, because they make it sound like removing life support is euthanasia, and it clearly is not. So I don't know if that's something that's just lost in translation or what, but
since that's his spouse, why isn't her opinion, since she is next of kin, why isn't that prioritized?
Well, because when you have, that's one of the main reasons that you should put that stuff on paper, because when you have disagreements, we're always gonna err on the side of life. And so it's just like if you have a do not resuscitate, but your family's in the ER with you screaming and yelling to do compressions, they're probably gonna do compressions, right? Because they're not gonna have a chance to sort that out. It takes a long time, right? And so in general, when there is big dispute, doctors will pull back and deliver aggressive care because we have to err on that side. And so the parents on this particular case are arguing that that was not their son's wishes. And so since he doesn't have documented goals of care for them to look at, then you end up in a court battle. Now, in the United States, I don't know what would happen if that happened, because he is the next of kin, and probably, I mean, it could probably delay things, but eventually she'd win. So, yeah. So voluntary stopping of eating and drinking, this is becoming much more common as we have a very elderly aging population. And it's a little bit different in the sense that you don't have to involve an outside person, so ethical considerations are very different. You don't have to have a physician's consent. And I've only had this come up a couple of times on hospice, when basically I've had people saying, do I qualify for hospice? And that's kind of a big question. Because obviously you're not going to live very long if you quit eating and drinking. The problem is it's very hard to quit eating and drinking. So can you go to the next slide? Thank you. So it's usually patients who tend to be a lot older. They have serious but not necessarily imminent terminal conditions. They have significant illness burden, and they're either in a state where it's not allowed, or a lot of people feel ethically that they don't want to put that burden on anybody else, including a physician. They want it to just be their own decision, and then they do it. And there was recently there was a case documented in the Washington Post where they followed a lady who decided to do this on like a weekly story. So it's definitely in the news much more frequently now. And I have seen a few cases of this here in Texas too.
So how long would someone how does that work?
Well, basically, it depends on how aggressive you are. If you just stop eating, it's really slow. If you stop eating and drinking, then it's still a lot slower than you think, because most people who are inactive, I mean, they'll tell you can only live 3 days without water. That's just simply not true. That's only true if you are a young, healthy person. But, like, for instance, if you have congestive heart failure and you've got all this fluid that's not supposed to be, it's everywhere it's not supposed to be, well, your body will slowly reabsorb all of that. And so it's almost like having this fluid stash in your body. And so it can take probably weeks to months. So it just depends on how aggressive they are, and if they take sips or if they don't take sips of water and things like that. But I think it's important that we talk to these patients about hospice and palliative care, and that we keep those lines of communication open, because I don't think it's unethical to provide supportive care to someone who's made that decision. And no matter how you feel about physician-assisted death, I don't think it's unethical to support them and provide symptom control. And one of the things that we recommend in hospice is we will give them these little glycerin swabs, because it will help keep their mouth moistened, because dry mouth is one of the things that bothers them the most. But most people, when you don't eat for a while, you don't feel hungry anymore. And so that's not usually the issue. But I do think it's also important to think about things like, is this person depressed? Is their underlying condition maximally treated? Have they been offered palliative care, so that we are really controlling their symptom burden and things like that? Because you don't want them doing that as a last resort. Okay, next one. I think it was interesting because there's a court case going on right now, this is kind of unusual, where in the state of Colorado, where it's legal to do physician-assisted death, a doctor working for a Catholic hospital system wrote a prescription in her outpatient clinic, not on the premises of the hospital, to a patient who requested it, and the hospital system fired her. And now she's suing. And she's suing for wrongful termination. And in the response, when I read this, I thought, I gotta look this up because I don't really understand this concept in a Catholic sense. So in their response, they basically said, we're using redemptive suffering as a justification for why we don't allow this. And it is a belief basically that your suffering not only allows you to identify with Christ, but actually can add to the mercy of, well, let me just read it to you exactly because it's hard to explain. But it's basically that human suffering, when accepted and offered in union with the passion of Jesus, can remit the just punishment for one's sins or for the sins of another, or for physical or spiritual needs of oneself or another. So although the most Christian traditions tend to see suffering as redemptive only in the sense that it allows you to identify with Christ and his suffering, they have an additional belief that it will actually mitigate sin and allow justification of sin, or kind of add to Christ's redemptive work. Does that make sense? So that was kind of their legal justification in saying that a patient should not consider physician-assisted suicide, which I thought was fascinating. But most Christian traditions are very on board with alleviating suffering. So, okay, New York State, this is kind of interesting. They have changed their advanced directives. Our advanced directives in Texas are terrible. I will just tell you that. Our forms are terrible. They're very non-specific. They don't allow you the choice to specify a lot of things about your care. It uses very vague language like, if I have a condition that is no longer amenable to treatment, I want comfort care only. But it doesn't talk about things like feeding tubes, or if you do all of that, you have to do it with a lawyer separately. And usually it's like a family law person that is well versed in these matters. So there's a lot of ambiguity in our language. And so we end up with a lot of situations that families don't know what to do about. So to fix that, I can't remember what that stands for now. The End of Life Consortium in New York has updated their what's called POST, which is POLST, that's their advanced directive laws and forms, to include feeding instruction. Because one of the problems with very advanced dementia is that if somebody else feeds you, you will live a very, very long time, often. And so they now offer people the option of opting out. And so they can say that they either want to be offered food, or they can say, if I can't feed myself, I don't want anybody to feed me. But it is very rare for families to feel comfortable enough to say, I don't want to feed my mom or dad, because we really equate feeding as not a life support, but as kind of part of caring, right? So that's becoming more of an issue as well, and I think things that you will see confronted when you're practicing medicine. So, and I think that as New York goes, other states will follow. It's been kind of the general trend. So, do we need physician-assisted death? And one of the things that really worries me is that polls have shown that 90% of patients don't know what palliative care is. And so they're obviously not accessing it if they don't know what it is. And we really need to be, as physicians in any discipline, on the forefront of recommending that to patients who are suffering with any kind of serious illness, because I think it alleviates their fear and worry. And whenever patients ask me about that, they say, oh, how much morphine would I need to take if I want to be done, or whatever, however they say it. My next question is always, what are you worried about? Because there is a worry and a fear behind that question. And almost always, if I can talk to patients and say, well, let's talk about what might happen if. So if they say, I'm really worried I'm going to not be able to breathe. Well, let's talk about what would happen if that happened. And I walk through, this is what we're going to do for you to make sure that you don't feel that at all. And then once they understand that, because a lot of very well-intentioned but uninformed doctors tell them things like, well, if you don't fix that heart valve, you're going to just not be able to breathe and you're going to suffocate. And I'm like, I actually had that happen to one of my geriatric patients who had decided not to fix his heart valve. He was like 95, he was completely asymptomatic, developed heart failure, and the cardiothoracic surgeon told him, if you don't fix this, then you're going to suffocate. And I was like, do you really think I would let that happen to you? But it was too late, it was already fixed. So anyway, I say that because I don't think they were trying to be mean. I think they kind of really truly believed that he needed a heart valve replacement. But there's just about no symptom that we can't palliate. I would say on my hospice service, 98% of patients die comfortably. I think there are a very small percent that are very extenuating circumstances. And so I think that we gotta be really careful that we're maximizing everything we possibly can in our armamentarium before people feel desperate enough to make this step, okay? And next one, thank you. So I think this is kind of an interesting question. When I first started doing hospice, I was like, why do people actually die from? Which sounds crazy, but I really had no idea. And you guys don't ever see that. I mean, you see death in the hospital, but when you're training, you're never gonna see it either. And so I looked and studied, I can't find any studies that address this question, but I will tell you from my own experience, about 80% of people, no matter what their underlying disorder is, die of infection. Because as you get weak from whatever problem, you develop swallowing issues, you can't move around very good, so you get bed sores, so you get pneumonia, you get bed sores, and they get dehydrated, so then they get urinary tract infections. But infection really is kind of the final endpoint for 80% of people. And the reason I tell you that is because patients will say things like, well, I don't mind dying of my cancer, but I don't want to die of an infection. Well, about 80% of the time, they're going to die of an infection because you can only get so cachectic and weak before that happens. Does that make sense? That was something I didn't understand at all. Even when I was an internist in office practice until I started doing hospice and palliative care. So probably about 10% are dehydration and adult failure to thrive. So that would be like that voluntary cessation of eating and drinking. Most people don't voluntarily do that, but what happens is, cancer cachexia makes you not want to eat at all, and they just can't force themselves anymore. Or they develop a problem where they simply cannot eat. They are so comatose and they have restriction to food and water, right? About 8% end organ failure. It's a lot less than you might think because people come to hospice for CHF, they come to hospice, but they don't often die from that. They usually just get weak and die from infection. And then I would say about 2% are sudden death from fatal arrhythmias to pulmonary embolus or something like that, where family just finds them dead or they just don't wake up the next morning. But unfortunately, we make it look like in TV that this is how most people die. And so that's what patients think. They're like, all my geriatric patients say, I just want to go to sleep one day and not wake up. And I tell them, well, that would be wonderful, but that almost never happens. Death is a very long, drawn-out process, which is why it's very important to have goals of care discussions. Because what families really need to know is, where's the line when you want me to not rescue you anymore? Instead of thinking they're just going to pass away on their own. That's just incredibly unlikely, especially in our system that is geared towards constantly treating complications. So we need to have that in our mind with our patients and with our loved ones. At what point are we not going to rescue them?
Question about since 80% of patients typically die of infection in palliative care, I'm curious.
Well, I would say that's on hospice.
On hospice.
On hospice, yeah.
Regardless.
Yeah.
So I guess, I don't know, I find that fascinating. I'm also a microbiologist, so.
Yeah.
With that, do you see people typically, just because they're so weak, they would die, or death comes faster to them because of infection, even though y'all probably treat it?
It just depends. Like the conversation I have a lot with people is, we're in a different place now. Let's talk about antibiotics and whether you want that or not. Mm-hmm. And so, initially in hospice, of course we treat it. We treat it as long as patients want us to. I've even done, like IM injection antibiotics at home for patients or family members really who just can't not do it. Like they feel so strongly that they have to have tried everything that they want to do antibiotics even at very, very advanced hospice care. So we will do it as long as patients desire it. But most patients get to a point when they say, I don't want to be saved at this point. Either they have very advanced cancer, or they're very elderly, or they have very advanced dementia. Like, we decided about a year ago not to give my husband's mom antibiotics anymore. Because, number one, every time we gave her antibiotics, they really made her sick. She developed all kinds of problems like antibiotic-associated diarrhea. And it was doing more harm than good. And we, because of what I do, were able to really have that conversation with her early on in her dementia. And what she said was, for me, the line in the sand is if I don't know who you guys are. Like, that is life not worth living to me. That being with my grandkids, being around my family, that's what makes me happy. And so when we got to the point when she doesn't know who we are, then that's when we decided we weren't going to do antibiotics anymore. Now, the ironic part of that is she's doing better without antibiotics. So I think we overuse those at the end of life. But, because it's been a year and still going. So, and she's had a couple of fevers, a couple of aspiration events, but she's gotten over them. So.
Follow-up question. I guess have there been cases, and maybe like how many would this apply to when, you know, that line wasn't drawn, yes, they still wanted antibiotics or whatever it was to treat the infection, but it failed because they were so weak.
Right, and that's what happens usually. I mean, I
Okay.
would say 98% of the time when we're recommending that you don't take antibiotics and people want it anyway, they are still gonna pass away. I'd say very rarely does it actually work, because I mean, they're really sick at that point. So, I mean, maybe if you stuck them in the ICU and you gave them lots of IV and, you know, TPN, and I mean, you really did the full court press, it might save them, but then their quality of life is gonna be really horrible. But I just thought that was interesting because I never knew that. So, okay, next slide. So palliative sedation. Palliative sedation is also another ethical conundrum for some people. I will tell you, it's not for me. But it's really only ethically justifiable, strictly from a medical ethics perspective, when the use of the sedative medication, at least in part, to reduce the patient's awareness of distressing symptoms that are insufficiently controlled by everything else you've tried, and that the level of sedation is proportionate to the patient's level of distress. And I will tell you, in 11 or 12 years of hospice, I've probably done this 4 times. I mean, it's very rare, but I have had some patient. I have one patient who was a huge opiate abuser, and so when he got sick with cancer, they just really did not help him. And even at just gigantic doses, were doing nothing. And so we were using lots of other medicines to try to control his pain, but he was just in agony, and his family was like, we cannot take this. And so he was not really eating and drinking anyway, but he was just so miserable. And the only way that we ended up making him comfortable was just a Versed drip. So we gave him morphine and Versed, and we just let it run until he passed away on his own. But I would say that's very, very unusual. But it is legal and it is justifiable. But there are some people who are very anti-physician-assisted death who would say that that's physician-assisted death. I personally don't agree, because you're not doing anything to hasten their death. But anytime you do a sedation measure that a patient does not have access to food and water, in some ways, you're going to be kind of hastening things. So,
Were you able to communicate with the patient that you were going to do a sedation?
Oh, he was begging. I mean, we literally tried several different things.
Okay.
I mean, he
okay.
was requesting it.
Okay.
His brother, the orthopedic surgeon, was requesting it. His wife was requesting it. We were just trying to make sure we had really exhausted every option first. So, and then at the point that we felt like we just didn't have any other choice, that's what we chose to do. And then I've done it one other time in a patient who developed, there's a condition that's pretty rare, but does happen, called opioid-induced hyperalgesia. I don't know if you guys know what that is, but basically if you use really high doses of opiates over a long period of time, you can develop a pain hypersensitivity syndrome where basically even just touching the person is painful. It's like they have some unique ability to really upregulate their opiate receptors so that they become hypersensitive. And so sometimes you can switch medications and do some things and back off and like add, there are things you can do, but in this particular case, we could not fix it. And she had a bad brain tumor and just intractable headaches. And so her family really, and she was not that cognizant at that time, said, can we please do palliative sedation? And so we sat down and, our protocol is that you have to have their primary care doctor or their referring physician to hospice sign off on it. So we will kind of present the case to whoever referred them and really talk it through. And like in this case, it was Dr. Pan, who's one of our neuro-oncologists here at UT Southwestern, and kind of told him all that was going on. And of course, he was happy to sign off on it. But we don't let a single physician make the decision. And then obviously you have to have a very good relationship with the family and make sure everybody is in agreement when you make a decision like that. So, but yeah, and their justification ethically is that it doesn't shorten a patient's lifespan, but I would kind of argue that it probably does. But the position will be that it doesn't.
Is this what the physician working for the Catholic hospital did?
I'm sorry, I can't hear you.
Is this what the physician working for the Catholic hospital did?
No, she wrote a prescription that was compounded to actually kill him.
Okay.
So that's different. So physician assisted death is when you specifically give somebody an agent to take on their own, right? So palliative sedation is done usually in consultation with the patient and the family. And the other thing that we will usually do is lighten the sedation from time to time to make sure that it's still consistent with the patient's wishes. So, we'll back off on a daily basis, the pump, and then let the patient become aware of what's going on and just chat with them for a minute and make sure they're still okay with what we're doing. And then that way we don't feel like they have not had the opportunity to change their mind, if that happens. Does that make sense? Most of them are usually incredibly desperate at that point.
Can you remind me what? Sorry. Can you remind me then what she was suing on the basis of again?
She was suing for wrongful termination
Because?
because she was fired by the Catholic hospital system for giving the prescription to the patient. Because the Catholic hospital system had specifically prohibited any of its employees from participating in physician-assisted death. Does that make sense?
Right. So I guess.
So she
What
did it
is her
anyway.
leverage in it? Like, didn't she break the policy?
Yes, however, she is saying that the policy is unfair because it's legal in that state and that she has the right of her argument is actually the opposite of, in states where physician-assisted death is legal, you can conscientiously object and not perform the service, right?
Right.
So she is making the counter argument that it is legal there. She is conscientiously objecting to what the hospital is doing, and they don't have the right to terminate her for doing a lawful, ethical action by the state medical board. Does that make sense?
Yes.
Okay. Yeah, it is very confusing. Yeah. Okay. And then palliative sedation to unconsciousness is kind of what we were talking about, except never allowing them to wake up again. But I personally do not do that because I feel like I really want to be 100% sure that I'm not standing before Jesus someday and he's like going, why'd you do that? For me personally, I really want to relieve suffering, but I don't want to do that if I'm causing the premature death of somebody. So we usually, like I had a lady that we used ketamine and Versed because she had very, very advanced breast cancer. And she had been in the breast cancer battle for like 10 years. And so what had happened was just over time with escalation of doses, they just stopped working. So we used an IV infusion of ketamine and Versed, but she was able to kind of lightly talk to us and take drinks of water. And so she was sedated, definitely, but not unconscious and could wake up and, that thing. So I don't think anybody's ever aiming for palliative sedation to unconsciousness. I think we're all, the basic tenet is as little sedation as possible to achieve comfort. Does that make sense?
But if someone is having trouble breathing,
well, then what we would look at is, are they having trouble breathing because of medication, or are they having trouble? We don't ever use anything for palliative sedation that suppresses breathing. Ketamine does not suppress respiratory drive at all. So that's why sadly it's a date rape drug, right? Because you are completely aware, and you have an airway and you can breathe, but you cannot respond to anything. Does that make sense? It's a dissociative drug that makes your brain dissociate from awareness. Does that
Didn't
make
you
sense?
say you gave morphine also?
Well, we do morphine for palliative, but it would be his regular dose. It wouldn't be like an escalated dose to achieve.
So in that case,
Sedation.
would you help them if they were going through respiratory depression?
We would probably back way off. Like we tell our nurses in those situations that we're aiming for a respiratory rate of 10 to 18. If it's below that, you need to call me. And so we would never do this without a nurse at the bedside. So a nurse is 24 hours a day at the bedside watching the sedation, recording vitals and all that stuff. Does that make sense? So if their respiratory rate started to drop, we would ease way back off on the medicine. And then if it's dropping because they're just passing, which is normal, then we would, of course, back off on all those medicines because we don't need them anymore. And also because we don't want the family to think that they're passing because of the medication. Does that make sense? Yeah, but it's impossible to know in that moment what's causing what. So we just decrease. And since it's an IV infusion, the effect is gone very quickly.
Would you also give them like the opposite drug, the Nafla?
Oh, you mean like Narcan? No, that would be horrible. Because the problem with Narcan is it completely reverses your pain control, right? So the only time I use that is in patients that are on hospice that have a history of substance use disorder, because I'm really worried that they're gonna relapse or something, or in patients who are on over, I think it's, at Parkland, it's like a knee-jerk over 90 oral morphine equivalents a day. They just automatically dispense it. But I tell my patients, do not use this unless you are because the problem in hospice is everybody's gonna get respiratory depression at some point, right? They're gonna die. And you don't want them to die a terribly painful death because you've suddenly reversed all of their pain medicine, right? So we basically try to tell our hospice patients, don't use this unless, the only time I've ever had a patient use it, and it was very appropriate, was in a guy with substance use disorder who relapsed, we did not know, was taking our drugs and shooting heroin. So, you'll get caught like that every once in a while, of course, but that's why, in that situation, of course, yes, you have to use Narcan, but does that make sense? Mm-hmm. Yeah. Let's see what we've left. Okay, so what agents do we use? There's nobody studied this formally. I will tell you what we do, which is the next slide, but we use these different medications, which I don't even know if you guys have had pharmacology yet, but there's several different things that have been reported in the palliative care literature as being effective, but no one actually studies this because obviously people don't survive it, so it would be a tough thing to study. So, and I've used Versed, I've tried phenobarbital, did not think that worked very well, so I'd say Versed's my favorite because it's super short acting, and you turn it off, it's gone. If there's any question about what's going on, like the daughter shows up from out of town and starts freaking out because she thinks that mom is killing dad, and then you say, let's just back off and you'll see that this is where he is, and just to kind of reassure people. Next slide. Let's see. Left. Okay, we talked about this really already. And I think that one of the most important things about this, regardless of how you feel about it, is that we need more access to palliative care, right? We need people to feel like they have the option of being comfortable no matter how far along their disease is, and that they know that we can help them to have a comfortable, calm death. And I think also educating people, when they talk to me about this, I'll say, I don't know, how many of you guys have seen that movie or read the book Me Before You? Anyway.
I've heard it.
Yeah, it made me really mad. I read all the books that come out about physician-assisted death because I'm curious what people are reading in popular literature. It's a novel, but in the novel, no spoiler alert. And I spoil it for you? In the novel, a guy becomes a quadriplegic and decides life is not worth living. He lives in Europe. He wants to go to the Netherlands and have be the end of it. So his family, in this effort to change his mind, hires this very charismatic caregiver. They fall in love, and he ultimately does not change his mind. But what made me really sad about the movie, there was no discussion about palliative care or hospice. And this was a guy who could have very peacefully, comfortably died from a complication without having to make this ethical leap that left his whole family feeling very uncomfortable. Because he would get horrible urinary tract infections, right, because he's got a chronic indwelling Foley catheter. And all they had to do was just let him get septic, which is actually a very pleasant way to go. And he would have become hypotensive and gone into shock, and he could have had a little morphine drip going, and he would have been just fine. But instead, they kept rescuing him from these terrible complications, and then in the end, he ends up going to the Netherlands and doing physician-assisted suicide, which made me just kind of angry because I think in real life that's not what would happen. Have you guys seen $1 Million Baby?
Yes.
Yeah.
Yes.
So that one makes me mad for another reason, because even though she is very verbal of not wanting things done, they continue to do them anyway, which is completely unrealistic. So anyway, all these movies make me mad because I recently read a book by Nicholas Sparks about a woman who goes into a persistent vegetative state supposedly for like months on end, and then wakes up, and then her husband is basically lauded for not having honored her wishes to remove artificial hydration and food. And I was so mad, I wrote him a letter. And I was like, this is irresponsible. Because, number one, that almost never happens. And now he's dangling this carrot for all these people out there that are reading his popular fiction and going, oh, I'm not gonna honor my family's wishes, even though they said, don't keep me in a persistent vegetative state, because they might wake up when this has happened like twice in the history of medicine. So anyway, I read all these books, but then I'm cursing the whole time. My husband's like, what's wrong with you? So, and the other thing is, palliative care discussions begin at the time of diagnosis. And I think that's very important. We live in an age of medicine where we have a million treatments and we do not have a lot of cures. So our ability to continue treating is very, very exhaustive. And so we need to, anytime we do any intervention that prolongs life, it needs to be with a discussion of when this will be stopped. So in other words, I have a patient right now who's got ALS, Lou Gehrig's disease, and we pushed her, and I feel really bad because now I feel like I didn't push her hard enough to make a decision about her artificial feeding, and she never would, and she just said, I trust my daughters. So now she's on hospice with me, and they are still feeding her, and she is completely miserable. I mean, miserable. If she is awake, she is crying. She can't say why. She can't communicate. It's horrific. And the daughters won't stop feeding her because mom never said to stop it. And they're very staunchly Catholic, and they feel like that is not consistent with their faith. And so we have kind of opted for slight palliative sedation. We just are sedating her most of the time now because she is so incredibly miserable. And but it would not have to be this way if I had gotten her to say, hey, if it gets this bad, please stop my feeding. Because people view that not as a advanced life support. They view it as killing them, right? Mm-hmm. And so if we were having that discussion from the time somebody ever put that in, that there will come a time in your life when you will not want this continued. What is that time for you? You know, like what quality of life is so low that you want us to turn this off? But we don't do that. And instead we end up with situations like this. So it's important that whatever discipline you end up going into, whatever life-saving thing you are offering, whether it's inotropes for heart failure or a left ventricular assist device or a defibrillator, there is going to come a time when we're going to want to turn that off for one reason or another. You get another terminal diagnosis, something. So, or you develop dementia, and then, you know, you're going to live a very long time because you have artificial life support going. So it's just important that anytime you make an intervention like that, one of the things we've really worked hard in the ICU here is time-limited interventions. Okay, we're going to try ECMO. We're going to try it for 72 hours. If we're not able to get you off of this at that point, we're going to shut it off. Because when you throw somebody a lifeline like that, they have to understand it may not work, and it may allow you to live a very long time in a very low quality of life. Does that make sense? I'll get off my soapbox then. And next one, questions, discussions, a lot of weighty information. I was trying very hard not to be pro one way or the other. About 99% of palliative care doctors are not pro physician-assisted death. I think it's because we see patients at the end of life and we know that we can make it comfortable. You know, 98% of the time. So I think they tend, as a general group, to be less supportive of that. And I myself am not. But I certainly understand why some people choose that route. And I think that the most important thing that we can all agree on is the less we do that, the better. Because we want to make sure patients are as educated as they possibly can be when they're making choices like that. And that we have really tried everything we possibly can. Does that make sense? Okay. Any other questions or thoughts? Mm-hmm.
How do you maintain autonomy in a situation, for example, when someone says that at this point in my life, when this thing is happening, that's when I'm going to determine my life not worth living anymore.
Uh-huh.
And then should they, like, let's say someone says that, like, if I get paralyzed, then if we were to write that right now, right? Because we don't have that. Like, if I'm paralyzed, doesn't end. I don't want to live anymore. And then they become paralyzed, and then change their mind. I guess you could just change that. But
right.
I guess that's a lighter example of something more serious. Like, how do you know that they wouldn't change their mind once they actually reach that place?
Well, you can change your mind, and oftentimes people do. But it's the rare circumstance that you can't communicate it. And that's kind of the situation I'm in right now with this patient. I would say that's very unusual. I mean, I've probably seen that a couple of times. There's a case, actually, there's a really good podcast, if you guys like to listen to podcasts, from, where did I hear this podcast? Oh, it was from NPR. It was on NPR. And it's of a woman who was a nurse. It's on Hidden Brain. Do you guys ever listen to Hidden Brain? It's a great podcast. It's all about your brain and how it works, and it's very fascinating. But it was a woman who was an RN, and she had taken care of a lot of patients towards the end of life and was very vehemently, I don't want this to be my life, I just want to go, developed ALS and changed her mind and ended up getting on a ventilator and living on a ventilator for quite a while. But I think I'd really encourage you to listen to the podcast, because I think that we document things, but oftentimes that documentation does not get honored because we don't speak to people about it. For example, one of the discussions I have with geriatric patients all the time is, does your mom or dad have a living will? Oh yeah, they have it. Do you have it? And they're like, no. Have you seen it? No. Do you know where it is? No. And so then it doesn't really do anybody any good, right? If the person that you have designated as your surrogate decision maker has never seen it. So I will strongly encourage all my geriatric patients and all my palliative care patients to please not only fill this out, discuss it with your family. I even give them homework. I say your homework for this visit is to talk about quality of life and sharing with your surrogate decision maker what things are really important to you. Because I can tell you, having been on the end of making these kinds of decisions now that our parents are much older, it's so much easier when you've had that discussion. Because we have so far only had to go down this road 3 times, but we are in the weird situation of having 8 parents and 2 elderly aunts that don't have children. So we were basically medical power of attorney to 10 people, which is unusual. But I think it's like selection bias because of what I do. So my aunt was very, very clear that living independently is the single most important thing to me. And she had a giant stroke. And despite her having conveyed that, her having all of that, I was arguing with the doctor that she could get better. And he said, it's going to make me tearful because I loved her a lot, but he said, I think we need a palliative care consult. And I said, that's my job, right? And he said, but it's not your job for your aunt. And he said, I think you should sit down and talk about this. And after I talked to the palliative care doctor, I realized I was totally being that family member that makes me a little crazy. So I'm a little more empathetic to them now. But and then the other thing that really helped me was looking at the scans. I was like, oh my goodness, this is a horrible stroke. And so I just finally realized there's no way she's ever going to get back to independent living. So we brought her home on hospice, and she stayed with us until she passed away. But and then my husband's dad, when he was first diagnosed, we were with Alzheimer's. We were able to really sit down and talk with him about what he wanted and didn't want. And so when he developed critical aortic stenosis, we decided not to fix his valve because he was otherwise incredibly physically healthy. And we were convinced that he was going to live to get very, very, very advanced dementia. And my husband once he developed the critical aortic stenosis and they were talking to us about surgery, my husband was really on the fence. And we obviously had not addressed that specific question with him. And he really wasn't in a place to discuss it logically at all. Like, you would talk to him and say, well, do you want to have the surgery? Well, of course I want to have a surgery. Well, do you want to risk your independence? I was like, no, I don't want to do that. And so we were not able to discuss it with him and get an answer that made sense. And so finally I took my husband to a dementia care unit and I said, this is where Pop is going if we do this. This is what's going to happen to him. Because his chances of getting through that surgery that big and on the other side, the way he is right now, are very small. Because he was still, he wasn't driving, well, he was driving like to the grocery store only. And then you just have to be prepared for the consequences because he had sudden cardiac death about 4 months later. And so I was not expecting that at all. I knew it was a risk, but it was a small risk. I thought, if anything, he developed heart failure first. Did not happen, was walking on the treadmill the day before he died. So, but even after all of that happened, it was such a blessing because his best friend came to us and said, hey, they'd had lunch together every Friday since college. And he said, I think we absolutely did the right thing because this was really getting bad, So anyway, it's hard, but I think you got to have those conversations because it's easier It's not easy. It's easier if you have.
For patients who, are looking for, or if you've had discussions with patients who are looking for physician-assisted death or something like that, or not understanding palliative care, and, they communicate to you about, like, well, I just don't want to be a burden on my family, or, this, like, kind of those situations. Like, have you been able to address that from, like, a Christian perspective to those patients of, like, hey, like, I guess, what does that mean for you? Where's your fear there?
Mm-hmm.
And, and kind of connect them to Christ at all, like, through that. I don't know why, like, what would your response be? Or
no, I think that's a very good question. And so I certainly talk it through with patients, and I will always ask patients if we're having some kind of ethical or moral dilemma. First of all, I say, help me understand what your faith background is. So is that a place we can connect? And if their tradition is, if they are open to hearing my opinion based on my faith, I will certainly share it. I just always ask them first. So I'll say something like, what is your faith tradition? Oh, I'm a Catholic, I'm whatever. And then I say, well, as a fellow Christian, having dealt with this a lot, let me just share with you a little bit on my views and, letting you know what is possible without having to do that. So then I think that oftentimes that's a big relief to them, because the main thing they're worried about is really suffering, right? I mean, loss of autonomy and stuff is bad, but suffering is up there too. And most of the times when patients are asking, and I don't think people ask that question a lot. They really don't. Not here in Texas. I think it's coming by the time you guys are all practicing. I mean, eventually this will probably be legal in every state. And I mean, if you just look at the trend and way things go on ethical issues, once you have opened Pandora's box, so to speak, it will continue to move forward. And it is very hard to go backwards. I mean, if you look at it, prohibition didn't work. Nobody has been able to overturn Roe versus Wade. I mean, these things are not going away. And so I think in your mind, you have to be prepared for the scenario when this will be legal in the state that you practice, and it will come up. And have considered in your mind how you feel about it, what you're going to do when that does happen. Very early in practice, I had a lady show up in my office who was pregnant, who just wanted a referral for her insurance to obtain an abortion. And I said, well, I'm really sorry. I'm not going to charge you for our visit, but I'm not somebody that can help you with this. And so just let her know that that was not consistent with my values. And so wasn't something I could help her with. And I just think you have to be as respectful and kind as possible, but, true to yourself too. So.
Do you have any specific, ideas or thoughts on, pediatric palliative care, on pediatric patients? Like, if you were to create another slide, what would that say?
So, obviously, in all the laws, you have to be 18 in the United States. In the Netherlands, you do not have to be an adult. But in the United States, you do. And so I don't think it's really an issue in the pediatric palliative community. And pediatric palliative care is so different, because if you are on hospice and you are under 18, you are still allowed to pursue aggressive interventions while you are on hospice. So it's like a whole different ballgame. So, and there's only one company in Dallas that does pediatric hospice, and I don't work for them. So I don't have any personal experience with it, except I've had lots of young patients, like 18 to 20, not lots. I've had some young patients, and it's definitely very different, but than taking care of someone who's 90 and at the end of their life. But ethically, I think that's a whole nother discussion. And as far as I know, I've not ever heard of anybody pursuing physician-assisted death in a minor in the United States. So, any other questions or thoughts? Okay, well, it's a lot to think about.